So now coming back, like just getting following your comments about disease volume. So we facing every day the problem that all the trials we had were done with conventional imaging.
Yeah.
CT scans, bone scans, MRI, and now we're doing. Everyone here said that we're doing PSMA PETs for everyone. So we are facing that dilemma that taking decisions based on a test that was not done in almost actually none of the clinical trials actually that we use. We're now starting the first clinical trials actually incorporating PSMA PETs.
Mm-hmm.
Do you guys follow that definition? I'd say if I see 5 lesions, 6 lesions on a PSMA PET, this is high volume disease, or you try to kind of tailor for every patient using other things, PSA, Gleason score, age, to really take that decision if you're more willing to treat that patient as a high volume or a low volume.
But what's interesting is like if you go back and read, now this isn't a de novo patient, but if you go back on someone that's had some type of pelvic therapy,
Okay.
then reoccurred. So if you look like Peter Ost or Phillips data,
Mm-hmm.
they use conventional imaging. I think it was Ost, but it may have been Phillips. So correct me on this. But they did conventional imaging to enroll patients, but they also did PSMA studies as well, and they blinded the reviewers to that.
The Oriole trial,
Right, Oriole, correct. But then when they looked at the data, even patients that had PSMA lesions that weren't treated, but they treated the other sites, they still did better.
They did.
And so the question is like, is there some kind of immune response going on in the baseline? I mean, it's a little bit over, my bandwidth to understand that, but it's interesting.
It's a little bit of a different situation, though. Oriole, Stomp, those trials are because what the goal there was really to try to delay or avoid ADT therapy, right?
Yeah.
That was their primary goal.
True.
Exactly.
It wasn't really, and they looked at PSA as a
Right.
progression as their endpoint, not survival or time to castration resistance, because none of those were beneficial in any of those trials. So I agree that I think where some of these signals come from, but it's a little bit of a different clinical scenario than the patient you're treating, upfront for cure,
Yeah, that's
as opposed
true.
to just because you're not or long-term response, I guess I should say. I think it's a little bit of a different patient population.
Yeah.
Because I'm still going to put that patient on ADT. I'm still going to put that patient on an ARPI.
Exactly.
I'm still going to
There's
treat the
not
primary.
an option to just
Yeah,
observe
exactly. Exactly.
It's a very interesting time in prostate cancer. I mean, we're in an era where all the previous studies were based on imaging studies or data that we have improved on, whether it's MRIs or Decipher scores. So everything in the past, we have to interpret with a grain of salt. So I tell patients that when I look at nomograms with them, I say, listen, this is previous data. We staged you better now. So your outcomes aren't going to be, exactly what these are.
But in theory, they should be better, right? Because we're seeing stage migration,
Right.
and
overall they will do better. They're
overall,
like
we should
they're
start
not
them
that
earlier
aggressive.
on therapy, and everything we've seen in the prostate cancer literature in the advanced setting, earlier has always been better.
Yeah.
So
100%.
Yeah, we'll see.
And the nomograms can be very frustrating for patients. They say,
Yeah.
Doc, I have this percentage chance of dying of prostate cancer. Well, this is a previous era.
Correct.
We're doing a much better job of knowing what your true cancer is now and treating that cancer appropriately.
coming in that direction because patients always ask, of course, prognosis, and there's something that could like change that prognosis. And I have the feeling that when things progress, we should tell patients that, that first numbers that we discussed initially, now you're like in a different basket because now you are, you have a good response of the treatment. So maybe you're doing better than the average. So are you guys using like PSA imaging? What kind of strategy to counsel patients and see how things are going after you start like systemic treatment?
How are we following, say, a patient that's castrate sensitive? Are we getting yearly imaging? Is everyone getting yearly imaging? I've heard some people trying to get PSMA scans yearly. To me, that seems, if their PSA stables, maybe a little bit overkill and difficult to get.
Mm-hmm.
But I don't think there's wide adoption of yearly imaging as well, which, you will find things. Like I had a man develop a sarcoma on me. That's a rarity.
Yeah.
But, it still happens.
Yeah. I think we can have a few patients that actually, not that few, but some fair number of patients that can develop disease even with no PSA progression. We saw this in like different trials, and there's actually specific publications on that. So
Yeah.
I think some imaging end up like being kind of a routine. One thing that's interesting, like doing PSMAs and then moving back to conventional imaging while you're following, if you don't have access to more PSMA, it's a bit cumbersome, but I see that sometimes it's the case for some patients.
Yeah, I mean, so generally speaking, it's about 10% of patients will have scan progression without PSA progression. In most of the trials. So I think the Radar 6 guidelines recommend annual scans currently. For that patient population, but they're looking at they basically recommend or support what they refer to as targeted precision imaging, i.e., PSMA PET scanning. In the patient where it's going to make a clinical difference in terms of their decision making. So somebody who is asymptomatic with a PSA that's nadir, who's doing well on drug from a quality of life perspective, I think it's sometimes hard to argue to go back to PSMA because you may only get so many shots at that.
Right. Save
Understanding that the sensitivity and specificity of CT bone is not what you want it to be, but those are your historical comparators. I do think we should go back a little bit and talk about the question that you asked about the volume of bony disease, because
this is important.
I think it's a really important question. And the CHAARTED data where we get this definition is all based on conventional imaging.
Yeah.
And we would assume that it's really underestimating the volume of disease compared to PSMA PET scan, which is really what I think you're trying to ask, right? So in that patient, they were probably much more likely to have a higher volume disease had we PSMA scanned that same patient in that same trial. So, to me, the question is whether we go for the Stampede, A-arm patient in that same situation, or whether you don't treat them locally and put them on to something else like a hormone-sensitive metastatic regimen based on PSMA 5, lesions, one outside the axial skeleton kind of situation. If they're visceral negative, I would still try to treat the primary tumor and do SBRT to those with 5. Anything more than 5, I wouldn't feel comfortable.
Yeah, I would agree. 5's a reasonable number. It's manageable for radiation oncologist, but above that, it may not make a big difference.
Yeah. Although they have this new Saber Comet trial with 10 actually lesions, the limit is 10. So let's see. Maybe next year we're going to be discussing on a number even higher than that.